good evening again, my dear friends and audience from all over the world. I'm so happy to have you again with us tonight. Tonight we are having the congenital heart disease course at CEC. This is the fifth webinar. It will be discussing the topic of patent ductus arteriosus, a case-based discussions. This webinar is the last one of the left to right chunks, and collectively those were 4 webinars after the introduction, which was the first one. Today the speaker is my dear friend Dr. Khalid Shams. He is a lecturer of cardiology at Helwan University, and he is a consultant of pediatric cardiology. Khalid will give us an overview about the embryology, the pathophysiology, and he will show us 4 different case scenarios for different types of PDAs, including the discussions about the diagnosis and the proper treatment plans for those PDAs, whether intervention or surgery. This will be moderated upon by my dear friends and colleagues, Dr. Muhammad Sabir. He is a lecturer of cardiology at Ain Shams University. He is a member of the congenital heart disease group there. And my dear friend and brother, Dr. Mahmoud Shahata. He is one of the eminent congenital heart disease specialists in Egypt, and he works with the congenital heart disease group at the famous Aswan Heart Center. So I'm glad to have you all on board, and I will pass the mic now to my dear friend, Dr. Khalid Shams. He will start sharing his screen. So please go on, Khalid.
Good afternoon, everyone. Thank you so much, Dr. Zahran. Would you please allow me to share my screens?
You may share now, Khalid.
Good afternoon, everyone. Again, first of all, I would like to thank my dear friend and colleague, Dr. Muhammad Zahran, for making this possible, a series of congenital heart disease webinars with a high scientific content available for everyone. And it's a pleasure to be on board today talking about the 4th kid in the left to right chance family, which is PDA. PDA is a persistent patency of ductus arteriosus resulting in a direct communication between aorta and a pulmonary artery, and it is thought to be due to deficiency in the mucoid epithelial layer and muscular media. PDA is the 4th limb of left to right shunts after ASD, VSD, and AVSD. PDA occurs in approximately 1 in 2,000 live persons, accounting for 10-15% of all congenital heart disease. And it's more common in females where the ratio of 2:1. The frequency of PDA increases with decreasing gestational age and birth weight, and that's why preterm delivery is one of the most important risk factors of PDA. Other risk factors include maternal rubella infection, birth at high altitudes due to low oxygen content, and some genetic factors and congenital anomalies. Regarding the natural history, PDA is usually benign with spontaneous closure in preterm neonates varying from 35 to 75% in the first year of life. Small PDAs in full-term neonates may close up to 3 months of age, and the rate of spontaneous closure after infancy is 0.6% per year. Although usually benign, however, a considerable percentage of patients with large PDAs develop Eisenmenger syndrome in infancy, as mentioned by Professor Wood in his quite old and nice article about Eisenmenger syndrome, which was published in the 1950s. So, large PDAs is a progressive aggressive disease and shouldn't be left untreated. Before proceeding to pathophysiology, I would like to highlight that ductus arteriosus is an integral part of the fetal circulation, and it's kept patent in the fetal life due to low oxygen content and placental prostaglandins. And several changes occur in the circulation immediately after birth, resulting in spontaneous closure of the PDA. These changes include spontaneous respiration with increased oxygen content, decrease in the plasma prostaglandin levels due to both placental ligation and the rapid decrease in the plasma prostaglandins due to rapid metabolism in the pulmonary circulation of the baby, in addition to the change in the pulmonary vascular resistance. There is a dramatic decrease in the pulmonary vascular resistance by almost 50% in the first few hours. Then the pulmonary vascular resistance continue to decrease over the next 6 to 8 weeks. If the PDA fails to close, it results in a left side volume overload, and this concept was elegantly illustrated by Dr. Haytham Hosni in the first webinar about the pathophysiology, that blood passes from the aorta to the pulmonary artery through the PDA, so an additional blood recirculates through the lungs to the left atrium and left ventricle, increasing the workload on the left side and resulting in pulmonary vascular congestion, or what is called pulmonary plethora. We have to keep in mind that the significance of shunting depends on multiple factors, including the size and length of the PDA, the transductal pressure gradient, the degree of the pulmonary vascular resistance, and pulmonary artery pressure, with the size of the PDA being the most important. And that's why PDAs are classified according to the size. And by size, we mean the pulmonary end of the PDA into 5 types, being a silent tiny PDA, which is usually less than 1 millimeter without audible murmur, a very small ranging from 1 to 1.5 with an audible murmur, the small ranging from 1.5 to 3, the moderate ranging from 3 to 5 millimeter, and the large PDA more than 5 millimeter. This classification is very important for nomenclature and description. However, it is somewhat arbitrary and shouldn't be relied on in deciding the further management, the mode and timing of closure, because it messes a lot of variables, including the weight of the baby, the pressure gradient across the PDA, the hemodynamic effect on the left side, and the pulmonary artery pressure. So we shouldn't depend only on the size, and we should always assess all other parameters. For example, it's completely different when you are comparing a moderate size PDA, or let's say a 4 millimeter PDA in a 4 kilogram baby from a 30 kilogram child. And here we will come to the first stop in this talk with 2 questions.
Okay, here is Mahmoud Shahata. I have the honor to moderate this elegant session. Thanks, Dr. Khaled, for the nice illustration of the first part of this webinar. Come to the first question, as Dr. Khaled mentioned, to identify how the size plays a role in this scenario and the BVR and the other variables. So we have a full-term newborn was delivered. Echocardiography was done on first day, revealing a moderate size PDA according to that classification. So it's 3 millimeter, the pulmonary end, and the baby has a pulmonary hypertension. And when do you expect this baby to be symptomatic? Is it the first few hours after birth, first few days, and first few months? The question is for the audience, depending on the inputs that we have from the first part of the lecture. So, as Dr. Khaled mentioned, yes, the right answer is B, first a few days. And this is why, because we have a moderate size PDA and pulmonary hypertension, this is in the first day of life by echo, and the baby is not symptomatic. Knowing the fact that the BVR is going to decrease rapidly in the first few hours of life and then continue to decrease over the 6 to 8 weeks. So with this moderate size PDA and pulmonary hypertension, this baby expected to be symptomatic after the first few days of life if this PDA doesn't close or small in size.
Thank you so much, Dr. Mahmoud. You are absolutely right. The main idea is the decrease in the pulmonary vascular resistance. As we just mentioned, the pulmonary vascular resistance decreased by almost 50% in the first few hours. While the pulmonary vascular resistance is high, we will not have any significant left to right shunting, and the shunting starts immediately after the decrease in the pulmonary vascular resistance.
Yes, it's true. Although the size is moderate size, as you mentioned, it depends here at the pulmonary vascular resistance at this age.
Here is the second question.
Good afternoon, everybody. First of all, I'd like to thank Dr. Khaled Shams for this elegant and simple presentation. And this is the second question in this presentation. Who do we expect to be more symptomatic? If we have the same size of the PDA in different weights of patients. So a 4 millimeters PDA is quite different when we talk about a 3 months baby with 4 kilograms weight versus a 3 years old child, 15 kilograms of weight. Can give the audience 2 minutes. Please choose the correct answer. Which one is more symptomatic? So yes, answers are starting to come. Of course, it's A. More symptomatic will be the younger child with smaller weight, smaller body surface area. He will have a greater shunt fraction, greater left to right shunt, and a greater hemodynamic effect of this PDA. In 3 months child, a 4 millimeters PDA is considered to be a large one. Probably he will be presenting with left ventricular dilatation, maybe left ventricular failure, and maybe persistence of pulmonary hypertension. When we talk about a 3 years old child, his weight is 15 kilograms. A 4 millimeters PDA will be a moderate sized one with probably milder hemodynamic effect and milder symptoms. Dr. Khaled?
Thank you so much, Dr. Muhammad. As you mentioned exactly, and I think the message is clear now, that the size is not the only factor that we should depend on. We should assess every single point regarding the hemodynamic effect of the PDA, the size and weight of the baby, and a lot of things instead. In 1989, Professor and Antoninho Krishenko and his colleagues introduced this marvelous angiographic classification of PDA. They classified PDAs into 5 types according to the angiographic shape. Type A is conical with a well-defined aortic border and constricted pulmonary end. Type B is short window shaped. Type C is elongated without constrictions. Type D is complex with multiple constrictions. And type E is elongated with constricted pulmonary end. This classification is as important as the classification according to the size, because it gives a figure out of the shape that we should always assess while doing an echo for a child with a PDA, because it has an implication on deciding the mode of intervention. And the next step in this talk will be with a case scenario.
So here we have the third question in this webinar. A full-term newborn with a history of maternal rubella infection, diagnosed to have a BDA at birth, discharged from NICU, and come back 6 months later with a history of recurrent lower respiratory tract infection, mild dyspnea, and proper weight gain. And by auscultation, we found a grade 3/4 continuous machinery murmur over the upper left sternal border. Is that enough to diagnose the BDA, or are we aim to look for another symptoms? So the question here, what other symptoms and signs would you like to search for? As we see in the image, cardiac-wise, we look at the active pericardium, because this BDA looks at least of moderate size, causing these symptoms, the recurrent chest infections and the dyspnea. Although the weight gain is adequate, but still the patient had a history of frequent chest infection. So we are expecting to have an active pericardium from the inspection and palpation. And by auscultation, we have, and also we have a widened pulse pressure and bounding pulses if we are palpating the peripheral pulses. And by auscultation, the murmur may be systolic at the left upper sternal border or left infraclavicular area, and may progress to continuous machinery murmur. And the respiratory symptoms, including tachypnea and apnea, may be related to the rubella infection and the central affection of this baby. So do you comment, Dr. Khaled, on this?
Thank you so much, Dr. Mahmoud, for your quite good analysis for the case. Regarding the symptoms of PDA, we have to keep in mind that the symptoms are variable depending on the degree of shunting. So we might have a wide spectrum of symptoms which depends on the degree of the shunt. The baby may be completely asymptomatic if he has a silent, tiny, or very small PDA, and as the size of the PDA increases, the symptoms increases, ranging from recurrent lower respiratory tract infection, dyspnea, palpitation, failure to gain weight, may proceed to congestive heart failure, and we may have signs such as tachycardia, tachypnea, wide pulse pressure, bounding peripheral pulses. On cardiac examination, we will definitely have an hyperactive pericardium, as you mentioned. We will have a continuous machinery murmur, and in case of a significant left to right shunt with overflow on the left side, we will have an apical functional mitral stenosis. In very late stages, with an increase in the pulmonary artery pressure, we will experience a marked improvement in the congestive heart failure symptoms, in addition to differential cyanosis. And differential cyanosis is a bluish discoloration of the lower extremities, sparing the upper limbs, and it occurs with a difference of more than 5% in the oxygen saturation. By auscultation, we might hear the murmur as only systolic, or it may become completely inaudible. And after diagnosing or expecting the child to have a PDA from the symptoms and from the auscultation, do we have other diagnoses that may cause a continuous murmur? Of course, yes. There are multiple diagnoses that may cause a continuous murmur, including the aortopulmonary window. The AP window is a defect between the ascending aorta and the pulmonary artery, causing volume overload on the left side, resembling the clinical picture of PDA. In most cases, it is non-restrictive, presents very early, and the treatment is mainly surgical. The other most important thing is the coronary AV fistula or the coronary cameral fistula, which is a fistula strict between one of the coronary arteries and a cardiac chamber, causing a volume overload on the left side if it is draining in a left-sided chamber, or on the right side if it is draining in a right-sided chamber, and the treatment is mainly depending on the size of the anatomy, which could be either an percutaneous or surgical closure. The other diseases that might cause a continuous murmur are absent pulmonary valve with to and fro murmur, VSD and aortic regurgitation murmur, peripheral pulmonary stenosis, collaterals in coarctation, systemic AV fistula, pulmonary AV fistula, or what's called pulmonary AV malformations, ruptured signs of valsalva, which usually presents in an older age, and venous hump. After diagnosing the baby with a PDA, which investigations would you like to do? And I would like to hear from Dr. Muhammad Sabir.
Thank you, Dr. Khalid. Regarding investigations of congenital heart disease in general, we usually start with simple investigations like ECG and chest X-ray, which give us a broad insight about the disease, whether it is a left to right shunt affecting the right side of the heart or the left side of the heart, whether it is associated with a disease associated with increased or decreased pulmonary blood flow. And then we go to definitive diagnosis by echo. So we start with simple investigations like ECG and chest X-ray. And as Dr. Khalid mentioned, PDAs usually affect earlier the left side of the heart. So we expect in chest X-ray the cardiomegaly to be with a prominent left ventricle and pulmonary artery, and we expect the ECG to show us left ventricular hypertrophy. So regarding chest X-ray, if we have a small hemodynamically non-significant PDA, it is usually a normal chest X-ray. We don't find cardiomegaly. When we talk about moderate sized or large sized PDA, we will find cardiomegaly with prominence in the left ventricle with the apex shifted outwards and downwards. We'll find increased pulmonary vascular markings, which is pulmonary plethora, and with in late stages of the PDA and presence of pulmonary hypertension, we find prominent pulmonary artery and pruning of the branches. Regarding ECG, as we said before, in a small PDA, which is hemodynamically non-significant, not causing increased left ventricular size, we'll find a normal ECG. If we're talking about moderate size PDA, the gold standard is that we have to search for left ventricular hypertrophy and left atrial enlargement, because PDAs as well as VSDs, both of them affect the left side of the heart. While in late stages, when the PDA causes pulmonary hypertension, we'll find right ventricular hypertrophy.
Thank you so much, Dr. Muhammad Sabir, for stressing on the basic tools like chest X-ray and ECG, because it gives us a clue about the significance of shunting, the degree of shunting, and as you just mentioned, that the X-ray and ECG findings could also be variable as symptoms according to the size of the PDA, ranging from tiny PDAs to very large PDAs with a clues to every type of PDA according to the significance of shunting. So we should always keep doing just X-ray and ECG for initial diagnosis. And as you just mentioned, that transthoracic echocardiography is the gold standard for assessment of the PDA. The most important views while assessing the PDA are the left parasternal short axis, the infraclavicular or what's called the ductal view, and the suprasternal. While assessing a child with PDA, we have to keep in mind few important points. Firstly, measuring the PDA. And by meaning measuring the PDA, we mean measuring the pulmonary end of the PDA. There is a very important point while measuring the size of the PDA. The size of the PDA should always be measured on a 2D image, and we shouldn't depend on color while measuring the PDA because it overestimates the size. Besides measuring the pulmonary end, which is the most important, we should always measure the aortic end, or what's called the ampulla. We should assess the size of the aortic isthmus at the site of the duct and exclude the presence of any associated coarctation. Also, we should inspect the effect of the PDA on the left-sided chambers, whether they are dilated or not, and we should measure the pressure gradient across the PDA. And it's always important to report the systolic arterial blood pressure because we can simply measure an estimate of the pulmonary artery pressure by subtracting the transductal pressure gradient from the systolic arterial blood pressure. And here we will come to the first case scenario for today. A 5-month-old child came to your clinic with his parents as recommended by his pediatrician after hearing murmur. His mother complained of recurrent attacks of chest infection, tachycardia, and tachypnea, and she stated that he is not gaining proper weight despite having a normal birth weight. On examination, the body weight was 4 kilograms. He had hyperactive precordium, bounding peripheral pulses, and continuous machinery murmur over the upper left sternal border with no cyanosis. So, what is the most probable diagnosis?
Dr. Khaled, I would like to share here in this case. As you mentioned, this baby is 5-month-old, and he's presenting with significant symptoms of volume overloading shunt.
Yes.
From the examination, you showed us that he's not gaining weight from the history, and his weight is 4 kilograms. He's having hyperactive pericardium, bounding peripheral pulses, and continuous machinery murmur. So now we should go for the investigations, starting with the basic and then go to the echo. But we suspecting from this case scenario the most common cause of continuous machinery murmur by this criteria. It's most probably maybe a moderate or a large size BDA.
Okay.
So let us see what we should in the X-ray or the echo.
We did a chest X-ray which showed cardiomegaly and pulmonary villicera. The ECG showed LVH and left atrial enlargement. And on doing the echocardiography, we had a large size PDA measuring 5 millimeter with dilated left ventricle and left atrium. So as you expected, Dr. Mahmoud Shahata, from the clinical history that we have and moderate to large size PDA with a hemodynamic significance on the left side, failure to strive. So what is your further management?
I think based on what you have discussed earlier, the classification showed us that the 3 to 5 millimeter is a moderate size PDA, but in this case, we have a 5-month-old baby. He's a fragile baby with a poor weight gaining. His weight is 4 kilograms, and he's having 5 millimeter here. I would consider it very large PDA with significance. So according to the standard treatment for these cases, it's a straightforward case for surgical ligation. Although we have some off-label use of devices in such cases, but the standard way of management for this case is the surgical ligation.
Okay, thank you so much. And I would like to hear from Dr. Hatem Hosni, if he's with us.
Hello, Khaled.
Dr. Hatem.
Very nice talk. Thank you, Khaled. So yes, this is a patient who has a significant PDA with a low birth weight, with low body weight, I mean. So yes, and the standard treatment nowadays for PDA is mostly percutaneous closure, as you've mentioned. But sometimes it's either the baby is too small, or if he's not suitable for a cath, then yes, we'd go ahead and do a surgical closure for that. So we usually, if it is an isolated PDA, we usually go through a lateral thoracotomy. And so it is important to determine the side of the arch before doing that, because the PDA would be on the side of the arch. So if left-sided arch, we do a left thoracotomy. So we have to know beforehand. On the other hand, if this PDA was associated with a significant intracardiac defect that also needed the operation, I mean, it's common to have a significant VSD and a PDA together, then we would go ahead and do that from a median stenotomy. Do the close the VSD and close the PDA in the same session. But on the other hand, if it is isolated, we must probably go through a lateral thoracotomy, and then identify the arch. Sometimes the PDA is really big, so that people might misinterpret it as the arch itself. And so people have to identify if the aortic arch, the descending aorta, and the PA branches, because sadly, some patients had their LPA or descending aorta ligated mistakenly as the PDA. So the recurrent laryngeal nerve there curves around the PDA. So we have to identify very well the arch with the head vessels. The aortic arch has to have arch vessels coming out of it. So a PDA will not have that. On the other hand, the recurrent laryngeal curves around the PDA. And we have to identify PA branches going into the lung to avoid such a problem. On the other hand, one of the tricks is to monitor pressure in the lower limbs while closing the PDA. So either by a pulse oximetry, or if the arterial line is already on the femoral artery, and then on test occlusion of the PDA with a forceps or something, the pressure should go high, and should become higher in the lower limbs. So if you're monitoring with the pulse oximeter, the oximeter waves should not be damped. And if you're monitoring with an arterial line, the pressure should go higher when we close the PDA. Most likely we close it by division. But to be able to divide the PDA, we have to put clamps on both sides and then cut in between, and then oversaw both sides without narrowing any of the aortic arch or the LPA. Sometimes, as you have just mentioned, PDAs can be really big and really short. So sometimes like a window like.
Yeah,
and then,
I just wanted to ask about this point, and it's a pleasure having you on board to give you insights about the surgical point of view. I have two questions. The first, you mentioned about the division. We have two techniques, the ligation and division.
Yes.
So we need to know more about the advantages of every technique compared to the other. And the second question about the Krishenko classification, which describe the shape of the PDAs. How does the shape of the PDA affect your surgical decision?
So we prefer to do a division for the duct because if we do simple ligation, there is a possibility that we leave residual PDA, or even if we close it initially, it can recanalize. So we prefer to divide it. Also, it has been described that ligature can cut through the PDA and then you get catastrophic bleeding later on. Fortunately, this is quite rare, but we're more concerned about the residual flow or the recanalization. But to be able to do that, as I just told you, we're going through a lateral thoracotomy, so we're not under cover of cardiopulmonary bypass or anything. And now we're dealing with the two biggest arteries in the body without having any safety measures. I mean, emptying out the heart or the aorta on bypass. So if the PDA is really, really short and very wide, this can be quite dangerous. And so if the clamps are not controlling well and we divide the duct, we can get really significant bleeding. So in this case, in the classification, that the window-like does affect a lot our technique. But on the other hand, having constriction on one side or the other side, if it's having multiple constrictions, I think this is more of importance to cath closure rather than surgery. What does affect surgery is the window type. The rest of the types doesn't make a lot of difference.
I think, Hatem, I have a comment here. If we have also constriction on one side, as Khaled mentioned, we should also inspect the surrounding structure, whether the aortic isthmus or the pulmonary, the left pulmonary artery, because this constriction might have a ductal tissue in this structure and doing some like a narrowing at the coarctation side or the aortic side, I mean, and narrowing at the origin left pulmonary artery.
Yes, it is not rare to get a ductus with an associated narrowing at the isthmus, like coarctation, or narrowing on the other side, on the LPA side, with origin stenosis of the left pulmonary artery. And as you've importantly mentioned, we have to determine the presence of such lesion before, because this might affect surgical intervention. We might need to deal with the associated narrowing also. One other thing that is of importance, which is different than your case, but in older patients, and essentially in adults, we frequently get calcification into the PDA. So if an adult patient presents with a PDA and we've agreed that she is not Eisenmenger, and we need to close that PDA, it is frequently calcified. And so ligating or dividing a calcified duct is a really, really dangerous thing. So in these cases, the approach would be from a sternotomy on bypass and temporarily going very low on the pump flow while dividing the duct. Also, it gets also then dangerous if a patient gets infective endocarditis on the PDA, and then the ductal tissue might be very friable, and then again the ductal control can be a bit dangerous.
Thank you
Thanks,
so much.
Hatem.
Thank you so much,
Thank you.
Dr.
Thank you very
Hatem and
much.
Dr. Hatem, for enriching the discussion. And so to sum up, we have a 5-month-old child who is 4 kilograms with congestive heart failure symptoms and failure to thrive and a large size PDA. So the management will be a surgical management. And to sum up what Dr. Hatem just mentioned, that the surgical closure could be done either through an lateral thoracotomy, median sternotomy in special cases with associated congenital anomalies, or it can be done through a video-assisted thoracoscope. The techniques are either ligation or division, and ligation has the complication of residual shunt, so division is preferred. However, when the duct is window-shaped or very short, it may affect the surgical decision. The most common complications are recurrent laryngeal nerve injury, recanalization in the ligation technique, and rupture in older patients with calcification of the duct. Case 2, a 1-year-old child came to your clinic with her parents referred from a pediatric surgeon for preoperative assessment before undergoing corrective surgery for cleft lip. Her mother mentioned that she is a normal baby with no current cardiological complaints. However, she had a past history of PDA since birth, which wasn't followed up. Her examination was unremarkable. Her ECG and chest X-ray were completely normal, and echocardiography was done, which revealed a tiny PDA measuring 1 millimeter, which was for sure unaudible as her examination was unremarkable and otherwise normal echocardiographic findings. And I would like to hear from Dr. Muhammad Sabir about this case. What would be your further management for this case? Would you advise her for a further investigation, or you would advise her for doing her corrective surgery?
Thank you, Dr. Khalid. So we are facing a 1-year-old child with a tiny inaudible PDA. This PDA is clearly hemodynamically non-significant because the child is asymptomatic, her examination is unremarkable, her ECG and chest X-ray are completely normal, and the echo showed a tiny 1 millimeter PDA. In such cases, we manage PDA by just following it up and giving prophylaxis against infective endocarditis before any surgery. So this child should be referred directly to her corrective surgery for cleft lip with no recommendations except for giving her the IV antibiotic half an hour before induction of anesthesia, and then just following up, annual follow-up for this tiny PDA, which will probably not need any intervention later on.
Okay, so your recommendations will be prophylaxis against infective endocarditis before the surgery. You will just reassure the family, and there are no needs for doing further investigations, or definitely there are no need for doing her cath. Am I right, Dr. Muhammad Sabir?
Yes, Dr. Khalid, cath has no role because this PDA is hemodynamically non-significant for the time being.
Okay, thank you so much.
Thank you.
Third case scenario, a 1 year, 6-month-old child came to your clinic with his parents. He has been following up small size PDA that was diagnosed since birth. His mother noticed recurrent attacks of lower respiratory tract infection. His chest X-ray and ECG were almost normal. The transthoracic echocardiography revealed small size PDA measuring 2.5 millimeter with a pressure gradient across of 70 millimeter mercury. The LV and LA were mildly dilated, and he has normal pulmonary artery pressure. So, Dr. Mahmoud Shaheta, what would be the further management for this case?
Okay, so here we have a baby, 1 year and 6-month-old child. So regarding the age, he's above 1 year or above 6-month-old, and he has a small, although it is a small sized BDA, but he has history of recurrent attacks of lower respiratory tract infections. And his basic investigation shows normal parameters regarding the ECG and chest X-ray. Although by echo, we have a small size BDA with a normal PA pressure as estimated from the pressure drop out through the gradient across the duct, which is 70. But we still have a mildly dilated LV and LA. And this chronic volume overload need to have a management. In the echoes that Dr. Khalid showed us a very nice ductal view. It shows us, it sounds a conical shaped BDA type A, which is the most common type, with a small size pulmonary end, 2.5 millimeter. So I think the next step is to go for elective transcatheter closure of this BDA. Anybody have a comment?
Okay, Dr. Mahmoud, so I can conclude from your comment that any symptomatic PDA with a hemodynamic effect on the left side is for closure, and having a small size PDA in the transthoracic echocardiography. So the preferred mode of closure would be the percutaneous closure.
Yes, I agree with you, Khaled. The standard treatment for such a case is transcutaneous closure. There is a lot of debates on the type of device or which type we use for 2.5 millimeter. Some people saying that if below 2 millimeter we can go for coil closure or using for such case 1 or 2 coils if we need. And some people saying that 2.5 millimeter, it's better to have one device to seal the defect completely with one step. We wouldn't go through this details regarding the techniques and the types of devices available,
Okay.
but the clear message here in such case was aging more than 6-month-old with a volume load BDA, although it is a small with a history of some symptoms regarding the chest infection from the history. So definitely is the case is indicated for transcutaneous closure.
Okay, and from your comment, you have just mentioned elegantly the shape of the PDA, that is, it is a conical shape.
Yes.
So, do you prefer to depend on measuring the PDA on this image with color, just to make the message clear? Or you would prefer to measure on the 2D image?
As we you mentioned, Khalid, before, the color usually overestimate the size of the BDA because of the fanning of the jet after this constriction. So it is better to identify clearly the BDA by 2D screening, and you can use a different views, starting from the short axis view, then the ductal view, which is infraclavicular, or some people say it is a hypersternal short axis view. Or sometimes if the chest windows is not that good, you can use a suprasternal windows to identify clearly the pulmonary end. And also, as Dr. Khaled mentioned before, we should do our effort to know the shape of the PDA. We measure the aortic end and the length of the PDA as well. And also having a look on the surrounding structures and the volume load effect, which is mentioned in the case scenario.
Thank you so much, Dr. Mahmoud. And the fourth case scenario, a 6-year-old girl presented with easy fatigability and palpitation. Her parents gave a history of having moderate-sized PDA diagnosed since birth with recurrent attacks of lower respiratory tract infections, dyspnea, and poor weight gain, which gradually improved after 3 years of age. So they didn't follow up anymore, having an evidence that her symptoms improved at the age of 3 years. On examination, she was alert, conscious with underbuilt, with occasional cyanosis, mainly on exercise and straining. She had a palpable second heart sound, right parasternal pulsations, and accentuated pulmonary component of the second heart sound with no audible murmur. Her chest X-ray showed dilated pulmonary artery and pulmonary oligemia. ECG showed RVH and left atrial enlargement. An echocardiography was done, which revealed a dilated right side with a moderate tricuspid regurgitation and estimated pulmonary artery systolic pressure of 90 millimeter mercury, given that her systolic arterial blood pressure at the time of examination was 100 millimeter mercury, and she had a PDA with free flow across. However, the size of the PDA couldn't be accurately measured. So, Dr. Muhammad Sabra, I'd like to hear from you about this child with her symptoms and how to proceed.
Thank you, Dr. Khalid, for giving a highlight about this important case scenario. So this is the typical case scenario when you leave a child with a large PDA untreated. When the child was young, her parents gave history of recurrent chest infections and dyspnea with poor weight gain, which are manifestations of left-sided affection, left ventricular dilatation, and failure with this PDA. Unfortunately, and we see this a lot in our country, that the parents neglect or they try to postpone any intervention for their child. After some years, we find that there is a gradual increase in pulmonary artery pressure and start in the occurrence of pulmonary hypertension. When pulmonary hypertension occurs, the child usually starts to improve regarding the signs and symptoms of left ventricular failure, but we start to see manifestations of right-sided heart failure. When this occurs, and usually will be associated with a decrease in the intensity of the murmur, usually parents continue in their ignorance of this congenital heart disease, and maybe some physicians, when they find the intensity of the murmur has decreased, they also ignore follow-up. So this is a very important point. When we see children with moderate-sized PDAs, we have to encourage for early management so that we don't get into complications of pulmonary hypertension. When we examine this girl after being 6 years old, we find profound manifestations of severe pulmonary hypertension in the form of low body weight, cyanosis on exertion, diastolic shock, which is palpable pulmonary component of the second heart sound, right parasternal heave due to right ventricular hypertrophy as a result of pulmonary hypertension and accentuated S2 with, as we said, no audible murmur. When we have equalization in pressure across the two sides of the PDA due to severe pulmonary hypertension, there will not be any pressure gradient between the pulmonary artery and the aorta, so no significant shunt across the PDA, so no audible murmur, which gives the false impression that this PDA has closed, which is not the right situation. Chest X-ray shows us the dilated pulmonary artery due to severe pulmonary hypertension and pruning associated with pulmonary oligemia, which means that we have starting pulmonary vascular occlusive disease. The ECG, of course, will show right, not left-sided hypertrophy due to an affection of the right side of the right ventricle due to pulmonary hypertension, and echo will, of course, show the affection of the right ventricle, not the left ventricle. And we had a pulmonary artery systolic pressure of 90 millimeters mercury, which is almost equal to the systemic pressure, as the systolic arterial pressure was 100. And of course, because of equalization of pressures across the two sides of the PDA, the flow of the PDA will not be remarkable in echo, as we have seen in the previous cases. We will have no aliasing across the PDA, so we'll have free flow and the PDA will not be accurately measured. So how to proceed in this case? So in this case, we have to go to catheterization and will not aim at closing this PDA except when we confirm that the pulmonary hypertension is reversible. So we'll have to start with right heart catheterization, measurement of saturations and pressures, and calculation of the pulmonary vascular resistance before oxygen and after oxygen. And if we find an improvement in pulmonary vascular resistance after oxygen, then we can go to closure of this PDA. If we don't find a significant decrease, so we have another maneuver we can perform, is that we can temporarily occlude this PDA in order to give this child every chance for closure. So as Dr. Khalid showed us, when we did hemodynamic cardiac catheterization at room air, we had an aortic pressure, systolic 100, diastolic 50, and mean 70, with an almost equal mean pulmonary artery pressure of 65 and a very high pulmonary vascular resistance, 8 Woods unit, which is considered a high one. But when we give 100% oxygen, fortunately, the mean pulmonary artery pressure dropped to 55 with no affection in the aortic pressure. And of course, we had an improvement in saturations, which gave us a pulmonary vascular resistance of 5 Woods unit, which is operable. So we in this situation, also we did balloon closure, temporary occlusion of the PDA. Unfortunately, the pulmonary artery pressure dropped again to reach a mean of 25. At this point, we can safely close this PDA. And in such cases, we usually prefer to close the PDA by a double disc device, not a classic PDA device, because we have almost equal pressures on both sides. So we have to have a disc on both sides of the PDA. So in this child, fortunately, we have reversible pulmonary hypertension, and we can proceed to PDA closure after we have confirmed that by temporary balloon occlusion. Dr. Khalid?
Thank you so much, Dr. Muhammad Sabr, for your meticulous explanation of the case. And we want to deliver here the message that we should exhaust ourselves in diagnosing and managing patients with left to right shunts and elevated pulmonary artery pressure, and we should give them every chance to have their defects closed and to avoid the Eisenmenger syndrome. And so, to sum up the management of PDA, how to treat PDA. The medical treatment of PDA has a very limited role and is directed mainly toward the management of congestive heart failure and the management of Eisenmenger syndrome. The role of medical treatment is very important in preterm infants, mainly including indomethacin, ibuprofen, and paracetamol, and if failed, then surgical closure would be indicated. But the role of medical treatment in term infants is limited. The PDA closure could be either percutaneous or surgical, as we mentioned throughout the discussion, and some historical background about the PDA closure. The first surgical ligation was done by Gross and Heppard in 1939. The first transcatheter closure was in 1967. The first device for closing the PDA was introduced by Professor Rushkind in 1979, and the first Amplatzer device, which is widely used nowadays, was in 2003. The types of closure, as we discussed, is either percutaneous closure, which is the preferred method because it is less invasive with a short hospital stay and no scars, and the innovation of the devices throughout the past decades has improved markedly, starting from the non-detachable coils, the one-disc device, and the two-disc device, and every single device has its own indication. The complications of percutaneous closure are vascular access complication, which is the most common, especially in very young child with low weight, the embolization of the devices, residual shunts, LPA origin stenosis, and iatrogenic coarctation, mainly when using large devices in low weight babies. The second choice is the surgical closure, and as Dr. Haytham mentioned, it could be either through lateral thoracotomy or video-assisted thoracoscope. We have both the ligation and the division techniques, and the complications are recurrent laryngeal nerve injury, recanalization, mainly in the ligation technique, and rupture. When to treat PDA, as we discussed throughout the cases, that a PDA should be closed if we have a signs of LV volume overload or pulmonary hypertension, but we have to make sure that the pulmonary artery pressure or the pulmonary vascular resistance is less than 2/3 systemic. As we just mentioned, the device closure is a method of choice when technically suitable, and small PDAs with audible murmur or hemodynamic effect should be closed, keeping in mind that tiny PDAs without audible murmur are contraindicated for closure, and this is according to the 2010 European guidelines, and we are waiting for the 2020 European guidelines. The Indian guidelines was published 1 year ago, and I do recommend for reading because it addressed a lot of controversial issues regarding the ideal age of closure and the method of closure. The Indian guidelines recommended closing the PDAs with congestive heart failure in the first 3 months of age, clothing the PDAs with failure to thrive without congestive heart failure in the first year, and small PDAs should be closed by the age of 12 to 18 months. Keeping in mind again that silent PDAs are not recommended for closure. Regarding the method of closure, having a weight less than 6 kg is an indication for surgical ligation. Percutaneous closure could be done off-label in certain cases. In babies weighing more than 6 kg, the decision could be individualized according to the size of the PDA, the size of the ampulla, the size of the aortic isthmus, the weight and body surface area of the baby. The drug therapy with indomethacin, ibuprofen, and paracetamol are not for term babies, it's only for preterm babies. Regarding the follow-up, the recommended follow-up is 1 year after either device or surgical closure, and infective endocarditis prophylaxis is recommended for the first 6 months after device or surgical closure. And we should instruct all patients to have a good orodental hygiene. Dr. Hatem, if you are with us, do you have any comments on the surgical closure regarding the Indian guidelines?
I actually agree on that, and this has been our practice since we're doing things. Maybe I would comment on the premature babies. So on the preterm, as you said, we usually try medical treatment with again, as you said, indomethacin and paracetamol, ibuprofen, but sometimes they do not respond to medical treatment, and then we need to do surgery. These patients are actually quite fragile with really high risk. Mortality can go as high as 10 to 20%, and this is not a surgical mortality, rather than a comorbidity of such patients. They frequently get, because of the very high flow into the PDA, so they get intestinal ischemia, necrotizing enterocolitis, intracranial hemorrhage. So anyway, sometimes, as you said, surgical closure is required, and then they are closed. Sometimes in some centers, they can even do that bedside, so that they do not move the baby and do a quick thoracotomy and put a clip on the duct. But otherwise, exactly as you said, I agree on what.
Yeah, and I think in preterm infants, the industrial innovation is progressing very rapidly. That nowadays we have a very slim devices that are pre-mounted on 4 Frenchies that would, I think, help in the future for managing the preterm infants with severe symptoms.
Yeah.
Sorry.
Okay. Thank you so much, dear
Thank
all,
you, sir.
for
Thank you very
listening.
Khalid, here's Mahmoud Shaheta. We have some questions from the YouTube. You still with me? Or?
I'm ready.
Okay. So the first question was regarding the first question in the talk from Hagar Mustafa. She's talking about persistent pulmonary hypertension at first 6 weeks of life may reduce the left to right shunting in cases of BDA, so delay the symptoms. Also, Mona Hashim commenting with the same thing, and both are.
I'm totally agreeing with this scenario. In the first question, we were just highlighting the normal scenario with the decrease in the pulmonary vascular resistance, mainly in the first day. So you will have a significant left to right shunt by the second or third day. But for sure, if we have a persistent pulmonary hypertension, the symptoms may be delayed for the first 3 months. I'm totally agreeing. But we were just discussing the normal scenario.
Another question also regarding the smoke. Is this for Dr. Muhammad Sabr and you? They asking why this case is need for infective endocarditis. The third case, the one with tiny PDA, before oral surgery, in spite that it is not cyanotic type. Could you clarify this issue?
If we look to guidelines of infective endocarditis, any patient with acyanotic heart disease and persistence of the shunt or residual shunt should receive prophylaxis against infective endocarditis before dental procedures. When we talk about Egypt, we don't fully control asepsis, so off-label guidelines, we usually give prophylaxis against infective endocarditis before any surgical procedure, whether it is a dental procedure or any surgery, because there will be a risk of infective endocarditis over this residual PDA. Even if it is tiny, it may turn to infective endarthritis, which is a big catastrophe.
I'm totally agreeing with Dr. Muhammad Sabr that although the trend in USA and the European countries that prophylaxis in such babies wouldn't be indicated, but I think in the developing countries, prophylaxis against the infective endocarditis would make our life much easier.
Last question, Dr. Khalid, from Hagar Mustafa. She's asking you to summarize the timing of PDA repair again, please.
Okay. Regarding the timing of PDA closure, as I just mentioned, it was elegantly illustrated in the Indian guidelines. That's why I do recommend for reading the ideal age of closure in babies with congestive heart failure. Closure is indicated in the first 3 months in the presence of a failure to thrive without congestive heart failure. So we are controlling the symptoms of the baby. We can give him some time to grow up and do the closure between 6 months and 12 months of age. As we mentioned in the second case, small PDAs, I don't remember if it was the second or third, small PDAs with audible murmur and hemodynamic effect should be closed between 1 and 1.5 years of age.
Okay, thank you so much, Dr. Khalid, for the nice and concise presentation. Now we move, and also thank Dr. Muhammad Sabr being with us and Dr. Hatem on board. And I think now we should move back to Dr. Zahran.
Thank you so much, Dr. Shahata.
Thank you so much, Dr. Mahmoud Shahata, Dr. Muhammad Sabr, for moderating this wonderful session. Thank you so much, Dr. Khalid Shams, for this very nice interactive presentation. We enjoyed it so much. Actually, it was so smooth and easygoing and interactive between all the audience and yourself and the moderators. You did a great job, and this was a very big effort. And thank you so much for this very nice webinar.
Always my pleasure, Dr. Zahran.
Thank you, Khalid.
Okay.
So
Thank
next
you,
webinar, thank you, Dr. Mahmoud and Dr. Muhammad Sabr. So next Saturday, we will have webinar number 6. This will be including the left-sided stenotic lesions. And next Tuesday, we will start the bifurcation webinars organized by CEC and moderated by Dr. Abdurrahman Gamal. And next Thursday, we will have a very interesting session about myocarditis with Dr. Ahmed Shahata from Cairo University, and Professor Hussein Hishmet will be moderating. So this is not a session to be missed actually. So see you next week, inshallah, and hopefully you enjoy what we are presenting for you. And thank you.